They also don't want their loved ones to be left at this sort of digital asset and messy mapped and not know how to do things like access what needs to happen to my loved one's bank accounts. How do I access it? Where do they hold this information? It's all these really new kind of digital era questions that are coming into that fold of, on top of having this natural conversation, now we have to get into the digital logistics of it too. You're already in a stressful situation, and then you're kind of compounding it with this distress about what would your loved one want us to do, because you don't have that documented.
So where is the digital piece coming in now? How's that topic starting to percolate? Welcome to the Digital Legacy Podcast, where we talk about death and dying in the digital age. If you ever asked, how do I protect myself and those I love if something unexpected happened to me? You're in the right place. I'm your host, Niki Weiss, and together we'll explore how to protect yourself in a world where both your physical and digital legacy leave a lasting impact. And welcome back to another episode of the Digital Legacy Podcast, where we talk about death and dying in the digital age. Today, my guest is Holly Vossel. Holly, you are one of the senior writers at Hospice News. And I am just excited to have you here. And let's talk hospice and palliative care. Welcome.
Yeah, thanks for having me. It's a big honor and pleasure to be a guest here. I'm actually a senior reporter for Hospice News. We also have Palliative Care News. That's one of our topical newsletters right now. So I started there as a freelance reporter in 2019, and then I joined full-time in 2020, right when that pandemic hit. So that was trial by fire into the end of life care there. But I received the senior reporter title in 2024. So Hospice News began publishing under senior editor Jim Parker, who is still at our helm. We're a publication of Aging Media Network, which has been acquired by WTWH Media in 2023. So we're one of a few healthcare publications that they have. It all kind of enters that realm of aging care, like behavioral health, your senior housing, skilled nursing. So it's really interesting the kinds of scope and how I fell into the hospice world is, I think, a little bit that is professional and personal. It's a different path that I think everyone kind of takes into the hospice care. And I get this question a lot of, how do you report in death and dying and serious illness, for every day?
It's a calling.
It's I think you hear that a lot,
Yeah.
right? Yeah, it's a calling, for sure. I think that as I love that you kind of preface this with, we're educators and informers, and I think that's how I kind of look at myself as a journalist in that role. We're truth seekers, we're storytellers, we are informers, we're investigators. It's really vitally important to me personally how I use my voice. I've always kind of wanted to use it in a impactful way. When I graduated with this journalism degree, I had an environmental, minor. I was like, I'm going to save the planet, and but I found myself
the people.
right. But now I'm more so on the people side, and I got really pulled into that healthcare world, and at the most vulnerable parts of healthcare delivery, both professionally and personally. I edited our healthcare accreditation and certification manuals before. I've edited books for authors who are going through that grieving process and highlighting that for others. I did even pharmaceutical proofreading spits. So I've kind of seen different facets of how our healthcare is delivered. And it's really inspired me, I think, to, in that bereavement component, to really dig into this hospice and palliative care space more. I've had that front row seat at the bedside too, even caring for my own parents and loved ones, and seeing different outcomes from that, family caregiver experience too. So it's really shaped me as far as how you can see what an unsupported, dying journey looks like, or uninformed, versus one that has had all that kind of planning in place. So that's what drives me forward and has driven me to this hospice and palliative space.
And what I was going to say is I'm still, I've been in the space since the early 90s. I think I volunteered having my parents pass away, when they were young, but then I started volunteering in hospice. I mean, even in the 80s, I was volunteering in nursing homes, in high school. And I still am boggled by, in 2026, people still don't understand what hospice is.
No. And I think that is, I mean, it was established, the Medicare hospice benefit was established in 1983. So it is, a 40 plus, year old benefit that is, largely underutilized. I think you'll hear that even in reports, and it's often confused with palliative care too. I mean, you mentioned the word palliative, and not many people, even clinicians, kind of conflate it with hospice. And I think some of that is that people don't understand that hospice is a free benefit. It's not something that you pay for. It is something that, whether you're an adult or child, if you have a life expectancy of 6 months or less to live, you're entitled to that benefit. And it includes emotional, physical, psychosocial, and spiritual support. And it includes this, very regimented what it needs. It's very regulated, actually. But palliative care is less so. And I think that some of that is some of the unclarity, right? And lack of awareness.
Well, it's interesting. First of all, many people don't even know how to pronounce palliative. So
Right.
it's, even to spell it and then pronounce it is kind of an awkward word. Hospice, when I talk to people, they think hospices, they are actively dying, so we need to get them on hospice. And that's also
Yeah.
need a myth. And I just have to share a quick story because I went through this with last week with a dear friend of mine whose mother has been for 4 years, end stage dementia, has been in a facility. She is they pay about $20,000 a month for her care. So it's $12,000 for her care, and then they pay like an extra $8,000 to have someone by her bedside. Granted, the family had those kind of assets, but the mother started failing. And I said, when she called to say, we're coming in because mom's failing, I said, is she on hospice? And my friend was, well, and she knows what I do. She's been through my final playbook. And she's like, why would we put her on hospice? She already has, we're paying for all this care for her anyway. Well, lo and behold, the mom is end stage dementia, failing,
Mhm.
and the doctors put her on antibiotics and fluids. And I was trying to explain to her, if she was on hospice, she wouldn't be getting that. And then I had to
Right.
go through the education, like, and that what is a natural death? What does that mean? So I just have to take a pause because that's just been very poignant in my head right now. And then here you and I are speaking, and I don't know how else to get the point across to people that hospice doesn't
Yeah.
mean like you're taking your last breath. 6 months or
Yeah.
less means you could be walking around, traveling.
Yeah. And I think that 6 months can sometimes, be very hard to predict from a clinical standpoint. And I think that that's part of it too. But it's also what's important, I think, to make sure that is highlighted is that, yes, hospice means you have to give up those curative treatments like an antibiotic or a certain medications, and that can be some of the barrier to it is that people don't want to give up, right? You think you want to not have to forego your curative treatments, which in some cases for palliative care you don't have to,
Right.
so they could be receiving
And that's
a
why
palliative.
the fee structure is different.
Right. And that is, I think, a really big confusing point in palliative care too, is that um, it's this sort of patchwork of payment is how I've heard it referred to a lot over the years of reporting it. It does address a lot of similar things that hospice does. It addresses those psychosocial, spiritual, physical, even
Care,
the
the daily, right?
emotional needs, right? And you can receive it at home as well, and in the facility in some cases, depending on how that works. But the patchwork of payment exists at state level and Medicaid systems, and then there's also Medicare. It's a component of traditional Medicare or Medicare Advantage, and you'll see it in accountable care organization or ACO payment models. So it kind of exists in those value-based programs too. But and not all states cover cover it, or their programs might look differently. You'll see a lot of palliative care funded by philanthropic support. But what that means is that a lot of things that are covered, it's mostly covered for things like clinical services. So things like social worker services or chaplains, some of those might fall out that side of that scope. So that becomes a cost, right, for either the patient or whoever the provider is that's trying to fund it. So that cost does represent kind of a barrier, and it's not part of a federal system where it's regulated in a standardized way. So you might see one palliative care programming offering a certain number of those, services that address the needs that we were talking about, or they might just, be a consultative, you know, service or an advanced care planning service. So it's really where you are and what it's based off is. It's supposed to be based off of community-based population needs. And so that changes from our geographic region too.
So the hospice news, this is really focused on professionals and within the hospice space, the
For
magazine,
our
the
readership,
publication.
do you mean for our readership?
Yes.
Yeah, a lot of our readers are those who are providing hospice or palliative care themselves. It can be anything from a clinician up to the executive level, a C-suite, those leaders and decision makers. We have social workers, nurses, and chaplains, and all kinds of workers in this space who read our pieces as well. We cover a wide range of topics like regulation, legislation, the policies that govern it. We also cover topics about operations and quality and bereavement care and caregiver support, at both the staffing levels and the family levels.
So where is the digital piece coming in now? How's that topic starting to percolate?
All over those, everything, it touches everything I just mentioned, from staffing support to finding things like operational efficiencies to kind of, there's healthcare workforce shortages that predate the pandemic and were exacerbated by it. And some hospices are competing with major, healthcare systems or hospitals for the same workforce, right? So it's really trying to extend those resources or make their workloads lighter so that they can sustain in their roles. And a large part of it is also that we have this swelling aging population in need of this care and not enough people to provide it. So they're really looking for ways that better reach or better identify patients. You're seeing predictive analytics be used too for patients and helping to kind of identify the red flags of decline medically, maybe in their charts. But that also introduces things like, well, how do we protect patient data privacy also? So there's a lot of those questions. Also, artificial intelligence and different uses for that, navigating ways to kind of make it a tool that augments and not supports the bedside help. So those are some of the digital pieces that I've heard so far come into play.
Well, it's fascinating to see where we've come again when technology was not part of care so many years ago. And here we are now. There's organizations out there, like Age Tech Collaborative, Age Tech Collaborative, which is part of AARP's. It's like their tech arm, and they're building out or supporting technology that will help people age in place. So maybe robotic, hoisters or different. I'm trying to think, not just robotics, but technology that will allow people to stay in their homes, age in place, and end of life probably as well, right? So they don't necessarily need to go into a facility or depend on a long-term care situation, especially since things are really expensive right now here in the States. And do you see palliative and hospice care embracing technology, or are they weary of it?
For sure. I think that there's a mixed balance of both, right? They're trying to warily be cautiously optimistic about technology's ability to kind of help them provide good quality care, right? So that's whatever I hear a hospice kind of trying to consider leveraging technology in the different ways, that thoughtful consideration goes into, what's the bottom line for them is how it impacts the patient's journey and the family's journey, right? How it impacts that quality that they receive. So as they're integrating a technology into their fields in any way, whether it's like, the revenue cycle management, the billing processes and trying to improve that, or whether they're trying to improve how they get their word out about, awareness to referral partners, that meaning people who refer to their services. So that would be like a doctor, right? How do they get the message out to patients and families and the general public? It's even how they use technology to communicate not just what they do, but how they do it, and help improve that reputation and awareness. What you hear a lot of is for that community outreach being a really key component in the technology considerations. Even AI and how it's driving people's, healthcare decisions. You see things like, Chat GPT or something like, how do I plan for my end of life planning? If you even put that question into an AI tool right now, how are people using that or relying on that is kind of a danger zone that I'm hearing too, is that it's all about making those informed healthcare decisions, but not relying on that technology to either help provide that care or inform it.
I mean, we're leaning, even in the death care space, we're leaning, or end of life, let's call it end of life space, we're leaning towards those data-driven decisions, whether it's in hospice or palliative or in just making those final, and I have to say, these final decisions. So my friend who I was speaking about with her mother, when I asked her, she told me that, mom is failing. And I asked if she was on hospice. And then she said, why should she be on hospice? She admitted to me that then while she was flying, to go see her mother, she was using generative AI to kind of flesh out her decision-making process. She used generative AI on the plane to write her mother's, to write an obituary. Like, that's to the point where she was leaning into it so much, as not just comfort, but also as a tool to help her synthesize her feelings, her thoughts, organize, a checklist. What does she need to do next? Like, this was a year ago. It's February 2026, just for reference point, right? So a year ago, most people couldn't even say chat GPT. Like, it was a slur. They weren't sure what letters was being used. So and now it's become kind of ubiquitous in many situations. And even to the point where here we are, end of life, and people are starting to organize their end of life and asking ChatGPT or some generative AI their end of life questions for their parents instead of the clinicians. So how do the clinicians feel about this?
I think that it's like the weariness, right? They want their patients and their families to have multiple reference points of understanding what their services are. Like, they want to know that you have options, right? You want to have autonomy and have options at the end of life. And that's what a concern might be, is that people are, as to your point, relying on that technology to help them understand things that they don't, and maybe be misinformed or not understand or be aware of that misinformation or that disconnection between technology and reality of what our services are to us. That you have this support that exists not just for yourself but for your family. Part of what hospices and palliative care providers do is give respite for the family. And if you're a person in that family caregiver role that really needs a break, yeah, that's a really important thing that you might want to know about. But how does technology inform you about that? Where does it guide you? What resources are you pointed towards? That's a concern, right? How do you know that you're getting that reliable um, and truthful information, that guides your health decisions? So my advice would always be, what I hear most of is to, use that technology as an augment and not a replacement,
Right.
to inform your decisions. And for people who don't have that, and that sounds great, go talk to your healthcare provider, right, about what you're thinking about. They should know how to have goals of care conversations with you and advanced care planning, whether you're near a person who's been diagnosed with a serious illness, or you just want to have a conversation about that because you have a chronic condition, or you have a loved one with a chronic condition and you want to know more about your options, use something other than technology to decide that. Use that human element in your research as you're looking into it. That would be my advice.
Well, that's great advice too. I mean, for people, and again, thinking of families who are, yes, we're aging, and yeah, we have the tsunami of aging that's coming on. But what I also talk about, is that we're dying longer. We're living longer, but we're dying longer. And how is that impacting on, hospice care and hospice and palliative, or palliative and hospice care as well? Or what are the trends that you're seeing?
Well, I think that trend of like living with longer disease trajectories, like your friend who has a loved one with dementia, I mean, that's uh, you're at one point. There's a lot of data now that's available that can kind of point to what I'm about to say, but a third of us are going to be family caregivers of someone.
I think we need to just put a pin in
Right,
that, right? You just said
a
a
third.
third of us.
A third. And that is happening at younger trajectories to people who are younger, who aren't as experienced. I had caregiver roles at younger point. I'm an example of that. I had it while I was in college at certain points. So no, I don't know many college kids that know how to, provide that palliative or hospice support to a loved one unless they are immersed in it or are, studying to be a clinician themselves, right? Unless, how would you know otherwise? So I think we do a poor job as a society about talking about it because we're very death adverse. We aren't a culture that welcomes that end of life as a stage that we can talk about with happiness. It's a very sad, of course, it's a
Oh, I
sad
want to open that one up. Holly, let's
moment.
open that
Of
one up.
course,
Why are we death adverse? Like,
shall
I
we?
don't get it. I don't get it.
I don't
Enlighten
either.
me
Because
based on your research, right? I sit there and I'm just like, why are you so like, why can't we talk? I don't want to talk about this. I don't want to talk. I'm like, why?
well, it's sad. I mean,
We
it's a
talk
final.
about erectile dysfunction all over, like all over, like every advertisement. Look, it's like ED. I'm like,
Yeah,
wait, we'll talk about that stuff, but we won't talk about like. Sorry,
right.
I had to go
But
there.
death comes for us all, right? None of us get a say in how it happens. None of us get, but death is something that is inevitable. And I think that's what makes life so precious for so much of us is that those of us that kind of deal in this space, it's so rewarding because you live every moment knowing that that is the end. You don't get to pick the end. The end could come tomorrow for any of us, but you don't get that autonomy there, but you could have more autonomy in how you live those final days if you know they're coming. So I think talking about it, we all know they're coming. So why aren't we planning for it?
Like you
Why
said,
aren't
yes,
we
positive. Why are we so like religious?
so
Like I don't know where the root came from. Like it's like if
fear?
I talk about
Well,
it, it's gonna happen. Go ahead.
yeah, I think the fear. There are some cultures
Of the
that are
unknown.
like
I'm
that,
sorry, I'm gonna get
where
philosophical with this. We're just because there's so few people I could talk to about this. We're afraid of the unknown. When sitting with your hospice patients, right? You've written, I don't know how many stories about patients who have gone through this. And
Mhm.
and I think this is hospice. Like, all right, let me just take it back to my dear friend. When they finally invited hospice, her aha moment was, oh, it's a philosophy. Like it's like I'm gonna there's this letting go process when you accept hospice into the conversation. And then the
Mhm.
fear kind of, it's space where I'm going to say where it allows like permission to start opening up about your fears around dying.
Yeah. You'll hear the word or the words existential distress if I can get them out correctly. But that fear, right, of what happens after death or what happens in my loss of, to my family members and my loved ones and my friends, like it's also that fear of finality, maybe that's the end. But that end can look very meaningful for for a lot of people if you are able to have the ability to put things in place, and you're able to plan ahead, and you do take some measures. Some of that planning ahead comes at cost, and that's where a barrier is too. Some advanced directives cost money to put into place, so they're not, it
But if
is
you
dying a
don't put it
good
into
death.
place, it costs like by not having the plan, by not having the conversations.
And that can also be extremely, you know, financially charged. So it's this question of whether, is a good death mean you have to be affluent? No, I don't think so. But
You
I
have to have a
think there is
plan.
a fear behind that, right? Yeah. Yeah.
So as an educator, how can we, I mean, you have the magazine, you have the publication. So what's the mission of Hospice News?
Yeah, I mean, we're an online publication. So it's our mission's really to do exactly what you're saying, is to inform and sort of educate through our reporting and make sure that we're covering as many perspectives of a certain topic as we possibly can, in a very, evidence-based way. We'll have different perspectives from those who are providing things in the field, who are experiencing these challenges when it comes to staffing or quality, or how they improve, experiences for patients and families. So that's really part of it, I think, at the heart of at least what I do as a senior reporter there. So for Hospice News, a lot of it is making sure that it's understandable to, and touching base on things that are really happening at real time in our healthcare system. Right now, you'll hear a lot of things, even related to Medicaid cuts that are coming, that were in recently passed laws, and that's another challenge too, and how that impacts, experiences for people who are, seriously ill, who might be eligible for things like hospice or palliative, and their ability to receive that care because the funding's not there. Or do we have enough people to provide this care for people who need it? um, Rural regions might not have a lot of
Yeah.
options, and then what do you do if you're a loved one who's in that rural region and you aren't? How do you support them? How do they support themselves? I was listening to one of your previous, episodes about, how to support someone when it's only just them, and how to build that connective support. I think technology comes into the fold there for sure, in how you even access care and find care for yourself.
Let's create like a clear roadmap for someone who, like, I wish my sister-in-law was listening, um, who is responsible for an aging relative, and they are maybe medical power, medical proxy, right? So they have a healthcare plan in place, but because that the digression of someone's care or health status is declining very slowly, they're less educated and empowered to take those steps and ask the question, is my loved one ready for palliative? Do they qualify for hospice? So what kind of information can we provide our listeners today, and questions that they might be able to either ask themselves or their care providers, to know whether they should be opening up that conversation or not? Let's start with palliative. Like, how does someone go from they've got a chronic disease, the doctors are not saying it's terminal, but they can see that very slow decline going on? What kind of questions can people start to ask themselves and their professionals?
I think it's understanding whether, your patient, your loved one is palliative, and they don't have to be terminal to be palliative. They can be diagnosed with a chronic, complex, medical, serious terminal illness, or serious illness, or terminal illness, right? It's first start there, is understanding that part. But if you have a loved one that is, falls into that category, important questions, it is to start that question and to say, if my loved one doesn't improve, what are some of their options, right? What are some of their options for care and support? And then what are also my options
As
as
a
I support
caregiver.
as a caregiver? Because that will connect you to resources. It will connect you and widen up that conversation of, and tell them you want to have a goals of care conversation that involves that loved one if they're able to. And then ask questions like, if my loved one's no longer to talk or speak or advocate for themselves, can we put things in place now while they're able to voice their wishes? Because the sooner that you can get that planning in place with your provider, you'll get more along the lines of advanced care planning, which is that goal of care. You'll understand what your person would have wanted if that big if they were able to tell you themselves when they're no longer able to care for themselves, what would they want? Let's get that now so that we know that they're going to receive what they want or make decisions that fall in line with those goals of care. And then your providers know, your healthcare team knows, you as their loved one know, and you know from then on you're doing the best you can to make sure that they receive it, and that's quality for that person and quality for the loved one too, I think.
And
So
again,
that's
I've shared
step
before.
one.
Sorry? Yeah.
I said I would say step one is to ask the conversation, and I'd
Early
say
on
step two,
though, and
yeah,
you hear me like deep breathing and like sighing because I'm feeling a moment of sadness because
yeah,
some people know that even as a professional, my father-in-law is 95 years old and he's in a veterans home. It's not going well. Like he can't hear, he can't see, can't toilet, can't like this is not quality of life for
yeah,
him. But and 10 years ago, he was going at 85, he was going to CrossFit. And if I showed him a picture, I'm like, Dad, you need to make decisions now while life is good because you're going to go down this path. And is this the way you want to live? And
right,
we've missed that conversation. And now it's become like a family, like it's contentious. Even in my family, it's contentious because we're not in agreement on his care. He's probably hospice appropriate. My sister-in-law
mhm.
is not interested in going down that path. So respectfully, to keep the family peace, so I can't emphasize enough. What Holly's saying is have the conversations early, document the conversations, right?
Document. I was going to say that's step two, and get them officially documented with your healthcare provider. Talk to your doctor about it. Ask about how it can be documented so that those wishes are honored, right? Because sometimes that can be, like to your point, a point of family stress. You're already in a stressful situation, and then you're kind of compounding it with this distress about what would your loved one want us to do, because you don't have that documented. So document it. um, and to your point, a lot of people don't want those. They don't want to be hospitalized, or they might not, or maybe they do because they don't want their loved one to kind of go through that like stress. I think knowing what they would want also creates that emphasis of like knowing that they're going to get as much of that as we can possibly give to, that person. But that takes conversations about it. And I think they're even harder to approach with the person who's in that, serious or terminal illness trajectory themselves, and they're sitting with it. I mean, they don't want to face it, but they also don't want their loved ones to be left at this sort of digital uh, asset and messy mapped and not know how to do things like, you know, access who needs to have the death certificate, right?
Right.
What needs to happen to my loved one's bank accounts? How do I access it? Where do they hold this information? And it's not, you know, I think of even digital access and how you share that with your family members and how you make sure the appropriate person might need account information. Will passwords update? How's that? It's all these really new kind of digital era questions that are coming into that fold of, on top of having this natural conversation. Now we have to get into the digital logistics of it too. So having all the pieces to that puzzle and having your family on board with that puzzle also.
Early on, while people are still able to have like, if my father-in-law
Right,
only was able to have that conversation 5 years ago,
right.
because like I said, people, it's just some of the changes are so incremental that you as the caregiver, you don't see them changing and losing their ability to make those decisions.
Yeah.
Palliative, and I also think palliative gives families a chance that if someone's hospice appropriate, but the family's just not ready, like they still want that option to send them to give them antibiotics or to be able to send them to the ER, then you keep them on palliative versus once they're signed up on hospice, that's you're basically saying that you're not going to seek that level of medical treatment. So really having that understanding, I think, is going to be just not just important, but like you said, documented. Does your organization, do you provide any sort of templates or tools that people can use?
We don't personally, but if you are seeking a good provider, they will. They will have things like advanced care planning, tools available that they can refer you to. And I think that for me, I just wanted to kind of circle back to that point you had made. It's just really important, I think, to understand that not all hospices provide palliative care, but a lot do. And I think what's an important part of that is that you'll get that kind of transitional support when your person might be eligible for hospice. And then you're with that same care team who has seen that journey take shape among not just the person with the illness, but their family members too. So they've gotten to know you, they've gotten to understand you, and they are going to try to treat you still the same as though every day is, an important, should be honored with quality. So I think having that access to continuous care can be a really important part of addressing things like anticipatory grief or planning out your memorial and funeral with your loved ones. I mean, that early on support is probably a key. If you were to go through an AI of this and say early on conversations would probably be the theme of our talk today. It's just having those conversations early. They're difficult, but it can also be, humor is an important part to bring into these
No has to
conversations.
cry. So no, I mean, I really do think that
Yep.
we
Have
bring
some
it
dark
over.
humor in there, sprinkled in there for sure.
That's why we have the death deck. I don't know if you're familiar with Lisa
I
Powell's death
am,
deck.
yeah.
How to gamify the conversation around death and
It's a
dying.
fun game, right? But that's one way,
Yep.
right? And just having those kind of organic conversations of like, look, if you're not able to talk and tell me this, what do you want me to know?
Right.
It's even just asking that simple question to your loved one. Because if they could tell you that they don't want to pass in this way, well, what can you do to help them not do that?
Right.
So yeah.
That's all good. Well, listen, and so I think we got our takeaways. Our takeaways was have the conversations early and document. I think those are our biggest ones. And if people wanted to get a hold of you, Holly, best place for them to find you.
You can just go to Hospice News. I am always reporting there. You can also find me on LinkedIn. You can just search Holly Vossel and you'll find me. So thanks for having me though, Niki. This was a really interesting conversation. I welcome more with you.
And you too. Thank you so much for joining. We'll end here.
Thank you for listening to the Digital Legacy Podcast, where we talk about death and dying in the digital age. I hope this conversation inspired you to take control and plan for the inevitable to protect yourself and those you leave behind. Don't forget to subscribe to our newsletter at digitallegacypodcast.com. Remember, life is full of surprises. What happens after you die shouldn't be. So keep your passwords safe and your playbook up to date.